so much, Dr. Vakas, for the invitation. Um, I'm Mohibullah. I'm an incoming PGY1 internal medicine at West Virginia University's Camden Clark Medical Center. The topic is folfoxiri plus bevacizumab versus folfox or folfiri plus bevacizumab for metastatic colorectal carcinoma. It's an updated meta-analysis that is built upon a previous meta-analysis. So, for colorectal carcinoma, it is one of the most common cancers known to mankind. It is the third most common malignancy overall and second most common in men. But the problem with metastatic colorectal carcinoma is over half of the cases diagnosed with colorectal carcinoma eventually develop metastasis, which worsens the prognosis. Surgical resection is still the first line treatment where it is possible. But for inoperable disease, where the disease has spread too far, or where we have a lot of metastatic activity in early part of the disease, we have to go for chemotherapeutic drugs. So in chemotherapeutic drugs, the first line is a combination of cytotoxics with a biologic. So we have two regimens, either folfoxiri, which is a cytotoxic combination, with bevacizumab, which is a biologic, or we can go with folfox or folfiri, which is a doublet chemotherapeutic drug. On the other hand, folfoxiri is a triplet. So we have two options to choose from them, and today we are going to compare them. So regarding methodology, it's a meta-analysis. So we searched PubMed, Ambase, and Web of Science from the inception till December 2024. So included studies were those in which there was a head-to-head comparison of triplet chemotherapeutic drugs like folfoxiri with doublet chemotherapeutic drugs like folfox or folfiri. Our primary outcome was progression-free survival. Secondary outcome included overall survival at 12 months and adverse effects at grade 3 or greater. Common adverse effects were neutropenia, diarrhea, febrile neutropenia, and those things. So data was pooled using random effect model and analyzed using RevMan 5.4 software. So our summary statistics were mean difference and relative risk with a 95% confidence interval. So on to our results. So in our final forest plots or result section, we had 7 studies that met our inclusion and exclusion criteria. 6 of them were randomized controlled trials, and 1 is an observational study. The total patient population is 1586. Let's move on to our forest plots, where all of these statistics are there. So this is our primary outcome, progression-free survival in months. The summary stats that we have used here are mean difference. It is important to calculate mean difference because it tells us how many months a patient can live longer as compared to the control group. So in triplet, you can see triplet has a increased progression-free survival by 3.081 months with a confidence interval of 2.557 to 3.606. P-value is less than 0.01, so it is statistically significant. And all of the studies, if you see individual studies, are pointing in the same direction. So it's a unidirectional forest plot. So yeah, that's it. On to the next, it is our secondary outcome. So we took adverse events grade 3 or greater. Adverse events are pretty common in chemotherapeutic patients. Like in some studies, they said 100% of the patients suffer from some sort of adverse events. But grade 3 and greater, we have compared them because they were significant. This forest plot slightly favors doublet chemotherapy. Like it has slightly less adverse events grade 3 or greater, but you can see confidence interval crosses 1. So it is not statistically significant. Again, the p-value is 0.86. It is not significant, but still we can say it slightly favors doublet chemotherapeutic drugs. Our third outcome, overall survival at 12-month interval. So again, this is also not statistically significant, even though progression-free survival is improving in triplet chemotherapeutic drugs, but overall survival at 12 months is not improving. But it is still favoring triplet chemotherapeutic drugs with 1.072 as its risk ratio. P value is 0.31, which is not statistically significant. Okay. So FOLFOXIRI plus bevacizumab can significantly improve progression-free survival in patients with metastatic colorectal carcinoma. And progression-free survival is pretty important when we discuss terminally ill patients with metastatic disease. Because there's no cure available. We cannot like completely cure them. They are in a hopeless condition. But what we can do is we can improve their quality of life for a little longer. In this case, it is 3 months that we can improve with the help of triplet chemotherapeutic drugs. The other two results, like overall survival at 12 months and adverse events, are not significant. They do not tell the superiority of one regimen over the other. Thank you so much. If you have any questions, please let me know.
Thank you so much, Dr. Mohibullah. If there are any questions regarding this study, Sir Mike.
Presentation. The superiority of progression-free survival, was it translated into better quality of life?
Progression-free survival by definition means the disease is not progressing. It is either stable or the patient is getting better, the disease is remitting. So it can translate into better quality of life because the disease is not progressing. So yeah, that's how I concluded that it means a better quality of life.
Actually, quality of life have different parameters. So if those parameters are not seen, then it can be a secondary outcome. So,
Yeah. Yeah, it is not directly calculated in this study. The direct outcome is progression-free survival. So yeah.
Okay, thank you, Dr. Mohibullah. Now I would like to invite him for his second presentation. Yeah, machine learning prognostic model compared with the MELT and MELT sodium scores for predicting 90 days mortality in liver disease. Dr. Mohibullah.
अब वहां से ओपन करेंगे, मैं यहाँ से कर लूँ. Okay, so this is my second presentation. Do you want to come? Okay. So it's a comparison of machine learning prognostic models with MELD and MELD sodium scores for prediction of 90-day mortality in patients with liver disease. It's a novel systematic review and meta-analysis. Meta-analysis on similar topic has never been done before. So, so this topic is important not because it's about machine learning or some futuristic stuff. It is because it gives us a realistic sneak peek into our nearby future, maybe in next 3 to 5 years. What we will not be seeing is machine learning taking over and doing colonoscopies for us. But what exactly we will be seeing is decision tools that will be helping clinicians make clinical decisions. And one of those clinical tools might be these machine learning prognostic models. So machine learning prognostic model is just like a normal prognostic model like SOFA score, MELD score, MELD sodium score. but it is developed on machine learning algorithm which has a tendency to improve itself over time through self-learning. What it exactly does is it makes hypotheses or mathematical equations and keeps solving those equations. If the equation comes with results that are closer to reality, it accepts those equations. And if it comes with equations that are far from reality or incorrect, it rejects those. So through these feedbacks, a feedback loop, it keeps on improving itself until it reaches near perfection. So it works just like traditional stats. It goes through cycle of data analysis and then pattern recognition, but that part is done by computer, and then it makes predictions. So it's comparison with traditional stats. Just like I talked, machine learning goes through cycles of feedback and improve over time. In the relationship between variables and outcome can change based on the feedback it received. So the equations that it comes up with are not static. They keep on changing over time. And it's a subset of artificial intelligence. On the other hand, traditional stats, it is also pretty similar, but it comes with equations that are static, that do not change. For example, MELD score, it hasn't changed in like 20 years. It has new variants, but they are also static. On the other hand, trends are identified under human supervision in traditional stats, and the relationship between variables and outcomes stay fixed over time. The difference between MELD variants and machine learning models. MELD has the advantage that gastroenterologists or clinicians in general trust it. It has it is time tested. It was implemented in 2002 first, and then came MELD sodium in 2016 and MELD 3.0 in 2023. So there's a lot of confidence behind this scoring criteria. But it is based on limited amount of data, like 3 or 4 variables are used in MELD or MELD sodium score. It comes up with it's a linear equation. Like it forms a straight line, or the rate of change is constant. So it's a linear equation. But we know in biological setups, linear equations do not work perfectly well. It has been proved in numerous studies. What machine learning model does is it is based on huge amount of data. It is trained on electronic health record system with huge amount of variables, like 30 or 40 variables, as compared to MELD score, which is on 2 or 3 or 4 variables. So it's an emerging technique and probably has a futuristic connotation to it. Methodology, again, it's a meta-analysis. We search PubMed, Embase, and Web of Science from the inception till December 2024. Inclusion criteria was only studies that had a head-to-head comparison of at least one machine learning model with either MELD score or MELD sodium score. And those studies should have a mortality reported at 90 days. Literature should be available in English language. And exclusion criteria was no past history of liver transplant. Like outcomes or prognosis are much different in patients who have been through transplant as compared to pre-transplant patients. So it could muddle up our results. Only one best performing machine learning model was included from each study. For example, if there are like 10 machine learning models in one study, we will only take one best performing one and compare it with MELD or MELD variants. It's a random effect meta-analysis using RABMAN 5.4 results. Okay, so this is our first plot, and it's a comparison of machine learning model with MELD score. So if we look at summary stats, which is ratio of means, it is 1.104, and confidence interval is 1.066 to 1.143. P-value is less than 0.01, so it is statistically significant. And it shows the superiority of machine learning model against MELD score, which is still the gold standard. If we look at individual studies, we can see, for example, done 2024, it is 0.791. This is the performance of machine learning model as compared to MELD score, which is 0.751, and the same trend goes in all of our included studies, 0.765 as compared to 0.599, and so on. This is our second forest plot. It is a comparison of machine learning model with MELD sodium score. So again, the trend continues. Again, machine learning model wins here. 1.089 is the ratio of means with confidence interval not crossing 1, p-value less than 0.01. So again, statistically significant. This is the complete breakdown of all the studies and their performance of machine learning model with MELD score and MELD sodium score. And also the names of machine learning models that were included are written here, like ensemble, artificial neural network, XCBCB, and so on. So the conclusion is machine learning model seems to have a better performance against MELD or MELD sodium score. So probably it's time we can change, or we can have a new model to predict prognosis. However, there's a high heterogeneity. If we go back and see heterogeneity in our studies, I square is equal to 99%, and in this graph, I square is equal to 51%, but that was expected because we have several different kind of machine learning models jumbled together in one place. They are inherently different, and they were bound to have different results. So heterogeneity is there. So what we need to do is we need to come up with one machine learning model that is integrated in our EHR systems, or in Pakistan's context, we need to come up with EHR system that is present across the board, even in public hospitals. That is still yet to come. But in order to implement this, we will need EHR system. Thank you so much. If you have any questions, please ask.
Okay, it was a supervised or unsupervised data entry, and was it a algorithmic learning patterns introduced into the machine learning process? What was the heterogeneity you just alluded to?
Heterogeneity is like 99% in second forest plot and 51% in the first one. But just like I mentioned, it was expected. And regarding supervised or unsupervised, so we do not have a machine learning model of our own. It's a meta-analysis. So we have a combination of machine learning models. If we go there and look here, it's Ensemble, ANN. Some of them are supervised, some of them are unsupervised. It's a combination of both.
Assalamualaikum, very nice presentation. I just wanted to ask that you said that we already know that all artificial intelligence, they improvise with more data entry. So to create a machine learning based model, what do you think? Is it safe for the patient? Because every time the machine will learn more and they would have different, different analysis and different indication for different stuff. So do you think it is safe for the patients that we directly go to a learning model and not to have, standard scores, which is, it's like fear, because as we are working in a transplant setup, we have to calculate MELD sodium. So because it is just a single score and it is very much, we can say that it's not different for every patient, but every time you will put different data, it will learn more and might have different better results. So I think it will be unfair to other patients who might come later for liver transplantation and stuff like that. So I still have doubts about that.
So the thing with machine learning models is that it does not keep on changing itself. What it does is, while we are training it, it keeps on improving. But once we have come up with a final equation, it does not change anymore. Like, it is static. We just, as a society, if we come up with a certain variant of machine learning model for liver transplant patients, we can just fixate with it for some time, like in order to not be unfair for certain patients. And regarding safety for patients, coming up with one standard machine learning model is a solution, I think.
What was the overfitting in your machine learning process?
What was the?
Overfitting. Overfitting is the terminology which is used for machine learning, and it is standardized from the beginning. Yeah,
again, just like I talked about, it is not one machine learning model that we're talking about. It's a meta-analysis. We have not developed any machine learning model on our own in this study. It's a combination. So different studies have different overfitting mechanisms that they have in place. While we are writing a manuscript, we have a big table that talks about overfitting and all those things. We are mentioning it in it, but for the abstract purpose, I don't have that data right now.
Thank you, Dr. Mohibullah. I have just one brief question. That were the machines that were used and those studies that were included in this meta-analysis, were that validated?
Yeah.
Okay.
They have like two groups. One is training group and other is validation group. So all of the included studies have both groups, like
Okay.
training set and validation set.
Okay. Thank you so much. As we know, the world is changing faster and AI might revolutionize a lot of things in our field. So maybe machine learning model may be used in the very near future. Thank you so much. We move to the third presentation. The hypoxic liver injury is an independent predictor of mortality in patients with ST elevated myocardial infarction. A systematic review and meta-analysis by Dr. Mahibullah.
Okay. So this is the last meta-analysis that I will be presenting today. So the role of hypoxic liver injury as an independent predictor of mortality in patients with ST elevated MI. So as we know, ST elevated MI or STEMI can cause end organ damages like AKI or other end organ damages. It can also cause hypoxic liver injury. So can we use it as a prognostic marker or not? That's the point of our study today. So why is prognostication important in the first place? In clinical practice, we have this system of triaging. Like we try to stratify risks in patients so that we can prioritize one patient over other, or we can prioritize one treatment over other. So that's why even in STEMI patients, we need some sort of prognosis tool. They have some prognosis tool available right now, but can we use HLI or not? That's the point. Methodology. We searched PubMed, Embase, and Web of Science. Inclusion criteria were studied that had a quantitative relation that were establishing a quantitative relationship between HLI and mortality in patients with STEMI. The comparison was between patients with HLI and patients without HLI. It's again a random effect meta-analysis. Results. In this meta, we included 5 full-text studies, like no abstracts were included. The most common study design was retrospective cohort. Mean age of patients was ranging from 58.3 to 66, which is typical of STEMI. Total patient population was 4987. The prevalence of HLI in total patient population was 21.3%. It signifies that we can use HLI as a prognostic marker because it is common enough. So our summary stat is risk ratio. Let's move on to our forest plot. So we have 5 studies here, and our summary stat risk ratio says risk ratio is 3.338 with confidence interval ranging from 2.678 to 4.161 with p-value less than 0.01, heterogeneity 24%. So what it means is patients with STEMI who end up with HLI have 3.338 times more risk of mortality as compared to patients without HLI. This is our only outcome in this study. So conclusion is HLI can be used as an independent prognostic marker for patients with STEMI. It can be used to stratify risks, optimize in STEMI patients to optimize their management according to the risk of all-cause mortality. So future studies should focus on exploring a linear or temporal relationship. So the point is correlation is not causation. So we have correlation there, but we do not know if HLI is a cause of mortality or not. In order to establish causality, we need to have certain parameters met. For example, there should be a linear temporal relationship, or there should be strength of association in place, or some biological plausibility, which I think is there. So we need to develop that in order to establish it as a cause. But for now, we can use it as a prognostic marker, independent of any other marker. Thank you so much.
Thank you so much, Dr. Mohibullah. Are there any questions from the audience? I have one question for Dr. Mohibullah. How was HLI defined in those studies?
I don't remember the exact lab values for HLI, but I remember they had some sort of definitions included in their study, but I forgot to look it up before this presentation.
Okay, no problem. I just want to get an idea that can we use that definition of HLI in our setup?
Probably yes. If it is based on lab values, we can get lab values for in order to establish if liver injury is there or not. I think hypoxic liver injury is a clinical decision, but gastroenterologists here can like define it better.
Okay, thank you. Thank you so much, Dr. Mohibullah, for presenting 3 papers. Dr. Mohibullah from National Multan. Now, for the next paper, I would like to invite Dr. Mehboob Jan. And the title of the paper is Factors Predictive of Lean Non-Alcoholic Fatty Liver in Disease in Pakistan Population. He is from SIUT. Please.
Assalamu alaikum. I am Dr. Mehboob from SIT. So today I will present my oral presentation of the factors predicting of lean non-alcoholic fatty liver disease in Pakistani population. So as we know, this non-alcoholic fatty liver disease is one of the most prevalent cause of the chronic liver disease in the Western countries, and it's approximately 25% of the variable across the different regions. While in Asia, it is about 15 to 45%. In Pakistan, it is estimated that the prevalence is about 14 to 47%. And traditionally, NIFL is closely associated with obesity, diabetes, mellitus, dyslipidemia, and metabolic syndrome. While BMI, which is a body mass index, is a key parameter in assessing the obesity and considering an important predictor of the NIFL. So it is also important to be remembered that South Asian, compared to their European counterparts, tend to have a high body fat percentage, particularly in abdominal fats, which is increasing risk of the metabolic syndrome even at the lower BMI. So BMI may not be fully accurately measure the body adiposity and in the Asian population. So there are multifactorial nature of a NIFL. So that can be encompassed the various metabolic and cardiac risk factors, and it is crucial to explore these association in context with the lean individual, as we miss a lot of lean who are having fat, so fatty non-alcoholic fatty liver disease. So it's important to know that the lean patient are not free of having risk factors. So multiple studies also show that low BMI, especially in Asians, possess a higher percentage of the body fat, which may be contributed to the NIFL development. And the interplay between the visceral obesity and metabolic disorders like diabetes, hypertension, and has been well documented. And this suggests that this factor may be present even in the non-obese patients. So, the Asian population, which exhibit a higher predisposition to insulin resistance and type 2 diabetes, are at low BMI threshold compared to their ethnic groups. So many other studies also demonstrate that the NIFL is also not uncommon among the non-obese lean population. So the aim of our study was to evaluate the factor predicting the lean non-alcoholic fatty liver disease in Pakistani population using a standard BMI in less than 23 kg per meter square. So this was a cross-section study which was conducted in SIUT Karachi, and this was a duration of over 1 year, and from November 2020 to October 31st, 21. And the inclusion criteria was that both the gender of age 18 to 70 who are presented with abdominal pain and having a BMI less than 23. And so all the other co-founder which can cause such a picture, like viral hepatitis, significant alcohol intake, hepatocellular cell carcinoma, and or any other malignancy were excluded to ensure the specificity of the study for NIFL. And the data was entered by using SPSS version 22, and the continued variable were expressed in mean and plus standard deviation, while categorical variable were expressed in frequency in percentage, while chi-square test was used for categorical data. And student t-test was utilized for comparison of continued data. So we actually done first univariate analysis, which was followed by the multivariate to find these predictors. So there were 194 patients with a BMI less than 23, and out of which majority were females. So this is a baseline characteristic of this study population, and which majority were female. And then we also divide them in the socioeconomic classes, and smoking, hypertension, diabetes, hyperlipidemia, and decreased HDL were the having a significant P value, and these were the predictors for the non-alcoholic fatty liver disease. And similarly, alkaline transaminases and alkaline phosphatase were also raised, so they were predicting the lean NIFLs. So this is already discussed. So in our study, diabetic smoking in hyperlipidemia and decreased high density lipocholesterol were independently associated with lean NIFL. And these were seen in univariant. So this is the hypertension, diabetes, smoking, hyperlipidemia, decreased HDL, ALT, and alkaline phosphatase level were having a significant P value. So these were proven that univariately that these are the independent risk factor. And similarly, these were further seen by using a multivariate logistic regression. And so diabetes, smoking, hypertriglyceridemia, and decreased HDL level were also having a significant P value. So, so the patient with a BMI less than 23 may develop NIFL. Ultimately, they may develop, can be associated with complications. So, lean NIFL population has statistically significant association with diabetes, smoking, and hypertriglyceridemia, and decreased HDL. So, however, we have a limited data, so it can be a good study. So, if we have taking a larger population. Thank you.
Thank you so much, Dr. Mahbub Jan, for presenting such a good paper. My only question would be, what was the prevalence of lean NAFLD in our setup?
Sir, we actually NIFLD, we were just looking we just actually predict the risk factors of this. Overall, NIFLD is about 14 to 47% in Pakistani population. Actually, we didn't just predict. We just see the. We didn't see the overall prevalence is that it is lagging. So we can do a study to see the frequency also. We just predict which are the risk factor for, or which can include which are the important factor which can lead to non-alcoholic fatty liver disease. So we didn't see the prevalence throughout the Pakistan. I think it could be another good study we can do.
Okay, thank you. And interestingly, the risk factors are the same as that we see in NAFLD, diabetes, hypertension, smoking. Thank you so much for such a nice paper. If there are no questions from the audience, I would move to the next presenter. Thank you. So our next presenter is Dr. Nida Rasool, and she will present predictors of frailty in patients with hepatitis C associated liver cirrhosis. She is from SIUT Karachi.
Assalamu alaikum. I'm Dr. Nida Rasool, working at SIUT Hospital, Karachi. So today my topic is predictors of frailty in patients with liver cirrhosis. So disclosure, no funding was provided for this study. So frailty is defined as a decreased physiological reserve, and it increases the susceptibility to adverse outcome due to various stressors like infection and ischemic events. Approximately 43% of the patients who are cirrhotic with advanced disease are frail. And why it is important? It is important because frailty is associated with psychosocial effects, increased rates of hepatic decompensation, prolonged hospital stay, delisting from transplant list, and post-transplant survival and ramification. So the objective of our study was to identify factors that are independent predictors of frailty in cirrhotic patients. So it was an cross-sectional study, and it was conducted at Hepatogastroenterology Department of Sindh Institute Urology Transplantation with the duration of 6 months. And the included patients were of both genders diagnosed with liver cirrhosis of any etiology on the basis of ultrasound abdomen, and they aged between 18 to 70 years. And only those patients were included who were overestimating frailty, such as cardiopulmonary disease, hepatocellular carcinoma. The reason was to remove the confounding factors. So how do you define frailty? Liver frailty index was calculated by using hand grip strength measured by kilograms, time chair stands, and balance testing. And patients with liver frailty index more than 4.5 were considered frail. So usually less than 3.2 are non-frail, and more than 4.5 are considered frail. So statistically significant variables were put on univariate analysis, underwent multivariate analysis to identify independent predictors of frailty in cirrhotic patients. And p-value of less than 0.05 were considered statistically significant. So this is the baseline characteristic of the studied population. The included number of patients were 132. And if you look at the age, so the average age was 47 years. Out of 132, 67.4 patients were males, 32.6 were female. The most common etiology that was in the studied population was hepatitis C, which was 52.3%, followed by hepatitis B, 33.5%, and 5.3 were autoimmune hepatitis, and only 3% were having NAFLD. And in terms of decompensation, we can see that 15.9 out of 132 patients were affected with had previous history of hepatic encephalopathy, and 6.1 had secondary bacterial peritonitis. 40.1 patients were having esophageal varices. 12% were underwent variceal band ligation. 9% had history of hepatorenal syndrome. And out of this 132 number, 38.6 patients were frail at presentation, and hospital admission were of 42.4%. So we continued this slide of baseline characteristics with the hemoglobin, which was on average 10.2, TLC of 5.5, platelets of 99.7, neutrophil count of 57.7. If you look at the mean bilirubin of the studied population were 2.8. Serum creatinine was normal, INR was slightly raised, serum albumin was slightly low, 2.9. Average CTP of the studied population was CTP B8, MEL sodium of 13.8, closer to 15. So the hand grip strength, basically the parameters through which we check the frailty were 3. Hand grip, which was average 20.4, balance test was 9.9 seconds, and time chair stand were 14.7 seconds. So the average baseline liver frailty index of the studied population was 4.1. So this is a comparison slide of different variables predicting frailty in cirrhotic patients. So this was the univariate analysis, in which in the column number 1, these are patients who were frail with having a liver frailty index of more than 4.5, and these were the population who were not frail and having liver frailty index of less than 4.5. So if you look at all the variables were significant, these variables including the gender, hemoglobin, TLC count, neutrophil count, age, CTP, MEL sodium, serum bilirubin, total bili, PT, serum creatinine, and sodium. The only parameter which was not significant on univariate analysis was lymphocyte count. So we put all these univariate significant parameters to multivariate Cox regression analysis to see which out of all these parameters were independent predictors of frailty in patients with liver cirrhosis. So we found that female gender, age more than 40 years, CTP more than B7, hemoglobin less than 10 gram per deciliter, and neutrophil count of more than 60% was significant on multivariate Cox regression analysis. And we can see here the odds ratio of age more than 40 was 9.9. So even out of all these, the age was more predicting that patient would have frailty. So this is just a quick slide to see that what the predictors we got significant on univariate analysis, and then we put on multivariate analysis. The highlighted one are the factors which were independent predictors of frailty in patient with cirrhotics. So liver frailty index was used, a liver specific, objective, quick and reliable tool that reflects extrahepatic impact of liver dysfunction. And the key predictors identified were advanced age, female gender, high CTP score, low hemoglobin less than 10 gram per deciliter, and elevated neutrophils percentage are significantly associated with frailty. So what was the clinical implication of this study? So addressing anemia and infection can improve quality of life, reduce complication, and enhance survival in cirrhotic patients, and we would have more patients which we can enlist for liver transplantation if they are not frail. So frailty has an impact in cirrhosis and associated with increased morbidity and prolonged hospitalization in this population. Managing reversible frailty factors can improve prognosis and enhance quality of life. Like gender cannot, it is not non-modifiable factor, but hemoglobin, managing infection, they can be modified. So we can improve the patient journal state of health. For the validation of our results and in order to make these results widely acceptable, multi-center studies with large sample size are required. Thank you so much.
Okay, sir.
The international standard, very good presentation. The international standard is for frailty index is 3. Why did you fix 4.5?
So the standard basically it has an calculated score, and if that score basically there are three parameters which I told: hand grip, time stay, and balance testing. So 3.2 is non-trial, 3.2 to 4.5 is in the mid, and more than 4.5 is termed as trial.
No, standard is 3. More than 3 is frail. No?
Sir, basically the formula
जिसने ये फ्रेलिटी इंडेक्स बनाया उसने 3 रखा हुआ, तो आपने 4.5 क्यों रखा?
बिकॉज हाँ सर मैं बता सर उन्होंने हैंड ग्रिप एक सिंगल पैरामीटर पे किया, वी यूज द स्कोर, वो कैलकुलेटेड स्कोर
नहीं नहीं, ये सारे हैं उसमें ना।
हाँ जी सर, उसमें 4.5 है।
ये सारे हैं ना?
जी सर, एग्जैक्टली तीनों पैरामीटर हैं।
हाँ, तीनों में 3 है, तो आप लोगों ने 4.5 क्यों रखा?
The mic to Professor Shehraman.
One of the key predictors for frailty was anemia. So have you seen into whether this was a iron deficiency anemia or like thalassaemic traits are very common, because we can't address improving the HP level in thalassaemic and other conditions while we can improve those who have iron deficiency anemia. So have you looked into the underlying causes of anemia as well, or
No
just
sir,
identity?
no sir. So this is a very great idea. We didn't actually went into the reasons of why they developed the anemia. We would have to see it. It might be because of portal hypertensive gastropathy, maybe cirrhosis, and then we have also a thing that we cannot, if somebody is having a compensated or decompensated cirrhosis, we have to keep the hemoglobin 9. So this is a usual practice that we don't over transfuse and overcorrect hemoglobin. But what we see and notice in our study, and it was a very interesting point, if we can highlight through multi-center studies that if this low hemoglobin is somewhat contributing to frailty, so we might need to put patient on a bit higher hemoglobin levels.
Very well presented and nice. Why you have not controlled group? Means those patients who have not disease cirrhotic. So a control group would have a better impact to compare it with the general population as well, the same age. So you have to. So if a control group was there, it would be much better study.
Yes. Yes, sir, I agree with that.
Anemia of chronic disease is more plausible, you can say, cause and etiology in this patient, because thalassemia is very rare and iron deficiency anemia can be one of the confounders in these patients.
Okay, thank you so much, Dr. Nida Rasool, for such a nice presentation. Now we move to the last paper by Dr. Danish. It will be presented by Dr. Danish. Role of Manleta model in predicting recurrence in patients with hepatocellular carcinoma undergoing transarterial chemoembolization. He is from SIUT Karachi.
Assalamu alaikum. My name is Dr. Danish Kumar. I'm from Institute of Urology and Transplantation. The topic of my presentation is role of Mann-Letta model in predicting the recurrence in patients with hepatocellular carcinoma undergoing transarterial chemoembolization. So, as we know that hepatocellular carcinoma represents the 6th most common neoplasm in terms of the incidence, and it is one of the leading cause of cancer-related death worldwide. Unfortunately, most of the patients with hepatocellular carcinoma are diagnosed at an advanced stage and are treated by the palliative options. And transarterial chemoembolization is one of the therapeutic options at that stage. So the aim of my study was to identify the non-invasive predictive factors and to build a model using these predictors suggestive of post-stage recurrence of HCC. So it was a retrospective study with prospective follow-up, and all those patients of either gender between age 18 to 65 having HCC undergoing TACE from January 2010 to December 2018 were included in this study. And those patients who had early stage HCC undergoing resection, advanced stage HCC with portal vein thrombosis, metastatic HCC, patient with poor ECOG status and advanced child class were excluded from this study. Data was entered and analyzed using SPSS version 24 and R software. Results were presented as mean and standard deviation for quantitative data and number with percentages for qualitative data. Continuous variables were analyzed using the student's t-test and categorical variables were analyzed using chi-square test. So statistically significant variables on univariate analysis subsequently underwent multivariate Cox regression analysis to identify the independent predictors of predicting post-ACE recurrence in HCC patients. So, and finally, a model was proposed using these variables on multivariate analysis, and area under the receiver operating curve was generated. At an optimal cutoff, the sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy was obtained in predicting post-ACE recurrence, and a p-value of less than 0.05 was considered statistically significant. Coming towards the results, initially 570 patients were taken, 247 patients were excluded either due to missing data or patients falling in the exclusion criteria. Then finally 323 patients were included in the study. Out of these 323, majority of the patients were male. Most common etiology of chronic liver disease was hepatitis C, followed by hepatitis B virus. Majority of the patient had single tumor, and post-ACE recurrence occurred in 186 patients out of 323 patients. And the timing of the HCC recurrence was at 12 months. Majority of the patients had recurrence at 12 months, followed by 6 months. So on coming towards the multivariate logistic regression analysis, this is a table showing the, it is showing the two groups, post-ACE recurrence, those patients who had post-ACE recurrence and those patients who do not had the post-ACE recurrence. 186 patients were those who had post-ACE recurrence. And majority of the patients who had post-ACE recurrence were males. They had age less than 50 years. They had higher number of neutrophils, low number of lymphocyte count. The tumor size was found to be more than 5 centimeters in these patients. Low serum albumin was found in these patients, and alpha fetoprotein, a higher value of alpha fetoprotein were found to be in those patients who had post-ACE recurrence. And these all variables were found to be statistically significant on multivariate logistic regression analysis. So based on these predictors, which we have found on multivariate logistic regression analysis, a model was proposed that was Mann-Letta, which comprised of male gender, age, neutrophil count, lymphocyte count, serum albumin, tumor size, and the serum alpha fetoprotein. And the points allotted to these variables were according to the odds ratio, and a nomogram was made with the help of our software, and these points were allotted according to that nomogram, with serum albumin were having the highest marks. So then area under the receiver operating curve was obtained for this Mann-Letta score, and it showed a very good area under the receiver operating curve of 0.98. with a high sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy. Then sub-analysis of this Mann-Letta score was done, and this is the box plot graph showing the higher values of the Mann-Letta model predicting post-haste recurrence at 3 months, 6 months, 12 months, and 24 months. With 12 months is showing the higher time is the timing at which the tumor recurrence was found. So it was found that tumor recurrence is directly proportional to the Mann-Letta score. The higher the Mann-Letta, the higher chances of patient having tumor recurrence. Then this Mann-Letta score was compared with other scores in predicting post-haste recurrence. And this is the graph showing the area under the receiver operating curve. And this blue dotted line is showing the area under the receiver operating curve for Mann-Letta score. And it was compared with other scores, that is alpha-fetoprotein, albumin index ratio, NLR to albumin, platelet to lymphocyte ratio, and neutrophil to lymphocyte ratio. And but we found that area under the curve for Mann-Letta was higher as compared to the other scores. And this table is also showing the same, that area under the curve for Mann-Letta was higher than the other scores. So coming towards the conclusion, Mann-Letta score has an excellent diagnostic accuracy in predicting the post-haste recurrence. However, further studies comprising of large sample size are required to validate this model. Thank you.
Thank you. It's very excellent presentation. My question is regarding the variables that you have used, like the lymphocytes and neutrophils and albumin and alpha-fetoprotein. The values that you have compared, whether they were pre-test or post-test.
Sir, it was before test, and it was these variables were found at the on the presentation. This score was calculated on the presentation.
The values that you have compared were pre-test.
Pre-test, yes, sir.
Thank you.
Thank you so much, Dr. Danish, for such a nice presentation. I have just a quick question. In your exclusion criteria, did you exclude patients with decompensated cirrhosis?
We only included those patients who were fit for the test procedure. So mostly those patients who had advanced child score, as I already mentioned in my study, that those patients who had child class C or B9, they were excluded from this study.
Okay. Thank you so much. Thank you so much, Dr. Danish, for such a nice presentation. So we end the oral presentation session with this. The organizing committee has decided that unlike other conferences, we will not rate the oral presentation in as first, second, third, but all the 6 presentations will be rated as best 6 presentations of PSG, and they will be given a prize money of 1 lakh and appreciation certificates in the end ceremony. Thank you so much all.
Assalamu alaikum. Good morning, everyone. In the name of one, the most merciful, the most gracious, we are going to start the next session. My name is Dr. Mushtaq. I am Assistant Professor of Gastroenterology, KMU Hospital and Research Center. Before starting the session, I would like to explain some ground rules for this session. The total time of this session is 2 hours. Time allocated for each presentation is 20 minutes, except the last presentation, which will be 10 minutes. So all the honorable speakers are requested to conclude their presentation within the given time. For audience, the audience are requested to write down their question. They will be allowed to ask questions at the end of the session. They can also share their questions with me on my WhatsApp number, which will be displayed on the screen. So now I would like to introduce the panel of experts and would request them to have seat on their respective chairs. The panel of so now I would like to introduce the panel of experts. So the panel of experts are Dr. Ghayasul Nabi Tayyib. I think he is not here. He remained as Professor of Gastroenterology and Head of Department, Lahore General Hospital, Lahore. He also remained as Dean Faculty, Gastroenterology, CPSP, and President, Pakistan Society of Gastroenterology in GI Endoscopy. Dr. Muhammad Sadiq Achakzai, he is Professor of Gastroenterology and Head of Department, Bolan Medical University, Quetta. He is also focal person to Balochistan Institute of Gastroenterology and Liver Transplant. Dr. Abdul Malik Achakzi, he is Assistant Professor of Gastroenterology and GI Division, Bolan Medical Complex Hospital, Quetta. Dr. Muhammad Usman, I think he is reached. Professor of Medicine and Head of Department, HMC, Hyderabad, Peshawar. He is also founding President, Pakistan Society of Physicians. Dr. Naeem Jan, he is Assistant Professor of Gastroenterology and ex-chairman, GI Division, Hyderabad Medical Complex, Hyderabad. Now, I would like to introduce the first speaker of this session. The first speaker of this session is Dr. Zahid Azam. He is Professor of Gastroenterology at Dow International Medical College, Karachi. He also remained as consultant gastroenterologist at Khan University Hospital, Karachi. He has multiple publications and research papers, particularly on HCC and viral hepatitis. He is going to talk on management of peripheral bleed, including esophageal and fundal. Sir, please.
Bismillahirrahmanirrahim. Thank you very much for the nice introduction. I'm not associated with Akhan anymore since 2016. I'm at South City Hospital now. I'm waiting for the presentation. Basically, this is a very common presentation of which is bread and butter of any gastroenterology training program, which is acute variceal bleed. Maybe this is esophageal or fundal varix. So the natural history of esophageal varices is the development of varices happens with HEPG. The normal HEPG is 5 millimeter of mercury, which is equivalent to the right atrial pressure, and then the pressure gradually rises with development of portal hypertension. And the magic figure that we need to remember is 10 and 12. At 10 millimeter of mercury, which is also defined as clinically significant portal hypertension, the varices start to develop. And then progressive dilatation of the varices happens, and then at 12 millimeter of mercury, most majority of the time, the varices gets ruptured, which is a catastrophic event for any patient of cirrhosis. The target is basically evolving into progression and then taking back to less than 10 millimeter of mercury or 10 millimeter of mercury. So there are two important sources that I need to cover in this talk, which is esophageal varices and gastric fundal varices. You can see here the spurting vessel in the esophagus as well as in the fundal varix. And when this happens, it's not only that we'll end up in variceal bleed, but it is the catastrophic event which leads to further decomposition of our patient, leading to liver failure. And aspiration of blood is one of the complications that may happen when there's a significant exsanguination. So we need to prevent that with some time. Prophylactic intubation. Most of the time in our clinical practice, we are not intubating our patient who are not a candidate for transplant. If a person is transplant candidate, we do everything. But this is the only thing where you should intubate your patient with catastrophic bleed or active variceal bleed to prevent the airway. And the recommendation is once you intubate, do the procedure, stabilize, and extubate as soon as possible. This is seen in our clinical practice that our anesthetists managing these patients are very much reluctant for early extubation. But the recommendation is early extubation as much as possible, because the target of intubation was not the airway, the lung parameter, but this was protection of the airway. And this blood in these intestine leads to coma, shock, delirium, DIC, as well as renal failure. So the management is initial management, which is resuscitation. A good resuscitation is needed before you take this patient for endoscopy, volume replacement. Sometime we may need to get group-specific uncrossed blood in very dire emergency situation where the patient is actively bleeding. Prevention of complications, so antibiotic is recommended then and there in the emergency room, and prevention of encephalopathy and prevention of aspiration. Subsequent management is control of variceal bleed with medicine as well as an endoscopy, and suppose this is uncontrolled, or then rebleeding may be needed, endoscopy may be needed. So the available option in our armamentarium are pharmacological therapy, which is the backbone of our armamentarium. Then we have endoscopic therapy, TIPS, surgical procedure, and balloon tamponade. I'm going to touch upon each and every in a short while. So early management is vasoactive. So previously we were using vasopressin and somatostatin. Nowadays terlipressin and octreotide are used. Terlipressin dose is 2 milligram at the bolus and 1 milligram 6 hourly. that we use in our community, but some recommendation are also 2 milligram 6 hourly. Octreotide is 100 microgram bolus and followed by 25 to 50 microgram per hour, and somatostatin again is 250 microgram bolus followed by 250 microgram per hour. Which vasoactive agent to use? So both vasoactive agent that we are using nowadays, terlipressin or octreotide, have equal efficacy in control of initial varicose bleed. Though in meta-analysis, terlipressin has shown mortality benefit by using it. There is a caveat that the person cannot be given terlipressin who have active angina or active cardiac event. Otherwise, we may give terlipressin in those patients. So, so terlipressin or octreotide, this is the data that we have, our local data. This was published in American Journal of Gastroenterology, where we concluded that the efficacy of terlipressin was not inferior to octreotide as an adjuvant therapy for control of esophageal varicose bleed and in-hospital mortality. The length of hospital stay was lower, statistically significant, but clinically it was not significant because this was few hours. So if that translate into at least a day or so, then we may say that this is. But the predictor of prolonged hospital stay were low hemoglobin, high blood pressure, low blood pressure, prolonged PT, blood at nasogastric aspiration at the time of endoscopy, and portosystemic encephalopathy already setting in when the patient is coming to us. So when, how long do we need to continue this vasoactive agent? ASLD in Baveno 6 consensus guidelines previously suggested that to continue this for 3 to 5 days. Though the new Baveno has shortened this to 2 to 5 days instead of 3 to 5 days. And pragmatically, what we are using or what we are doing in our clinical practice, majority of the time because of cost, as well as if the person is low risk, we don't give for 5 days. We stop once we think that the patient is stable. So to answer this question, we did a randomized control trial of whether we can give short course, which was defined as 24 hours of terlipressin, given as 2 milligram bolus and 1 milligram 6 hourly for 24 hours versus a control of 3 days, 72 hours of terlipressin in acute varicose bleed. These were the patients who were randomized who had low risk of bleeding. So we excluded those patients who have spurting vessels and hemodynamically unstable at the time of admission. And the third exclusion was HCC because the pressure dynamics are different. So apart from them, we enrolled all patients who were willing. And this is the survival plot, where you can see that there was no difference whether we use 24 versus 72 hours of terlipressin. And this, we were using it. We were doing it in our clinical practice day in and day out. Low risk patient getting stabilized, stopping terlipressin after endoscopy within 1 or maximum 1.5 days. So antibiotics, yes, this is very important because there is a translocation of bacteria because of the breach. So this is recommended that that antibiotic should be given. The best the recommendation is ceftriaxone 1 gram, or sometime we may give 2 gram. Easily saying 1 gram once a day, and stop if after 24 to 48 hours when there is no evidence of other infection. Subsequent management is of esophageal varicose bleed is initially we need to control with esophageal varicose band ligation for gastric varices. The subsequent management is slightly different. So we all know about endoscopic band ligation for the management. There are some problem when we are dealing with acute GI bleed. So the slender decrease the field of view, as well as sometimes there is friction with blood-filled clot in the, so we need to wash, and sometimes we need to capture blindly and then do the endoscopy. Sometimes we need to switch from band ligation to sclerotherapy, though nowadays sclerotherapy is hardly done. This was the study that was again a local study done by Shahid Majid and myself at Khan University many years ago, where we was saying factors that were determining clinical outcome. So the bad outcome predictors were, you can see here, the person having diabetes, the person having active bleed at the time of admission, and bilirubin of 3. So they were poor prognostic factor at the time of enrollment. Management of failure to control bleed. Suppose majority of the time we are able to control, and we keep them in high dependency unit and then transfer to ward. But sometimes when there is failure to control bleed at the initial time, re-endoscopy is recommended with band ligation or endoscopic sclerotherapy sometime. We can buy time till support is arranged with using balloon tamponade in area where or in services where TIPS is available. We can take this patient for TIPS. Other option is fully covered self-expandable retrieval metal stent and sometimes surgery. Though this is the balloon tamponade. Everyone working at GI unit must be aware of this. There is a esophageal as well as the fundal limb. This is the TIPS schematic diagram, and then this is our real patient where TIPS was was given to salvage. So esophageal varices are different as compared to gastric varices. We told about that the magic figure of 10 and 12. In gastric varices, this doesn't follow 12. So they can bleed before the pressure of portal pressure reaches 12, and there is 20% of the variceal bleed are from gastric varix. This is the Sarin classification, where the first one, GOV1, is the extension of the esophageal varices into the stomach, which is in continuation, and the management is same as the esophageal varices band ligation. GOV2, which is extension of varix into the greater curvature of the stomach, where we need to do obturation of the varices. And same is the case with isolated gastric varix 1, which is in the fundus and which is not in continuation with the esophagus, and ectopic varices, which may be in the antrum, duodenum, pancreas, or rectum as well, and distal intestine. So this is important. Portal pressure gradient of 12 millimeters is the threshold for varices, and gastric varix, as I told, behave differently, so they can bleed. Again, management for pharmacological management is almost the same. Octreotide or terlipressin. As I told you, GOV1 are dealt similarly as esophageal varicel. So endotherapy can be given with the esophageal varicel sclerotherapy, ethylamine oleate, which may be less effective. Nowadays, ethylamine is not available, so sometimes we use STD. And then, skipping this. So endoscopic gastric varices can be dealt with hystoacryl, which is N-butyrylate to cyanoclate, or this could be butyrylaclate, isobutyrylate too. So the two types of glue that are available, the second one is available in UK market, and the first one is available in European as well as our market. Thrombin glue, and then studies have proven them superior to esophageal varices sclerotherapy or band ligation, and variceal obliteration is majority of the time this 90% effective. We can see here this is the punctum that we can see from where the bleed and we inject, and this is follow-up where the glue has congruent. So what is the local prevalence of gastric varices? Gastric varices prevalence was 22% in our hospital database of 10 years at AKU, and primary hemostasis was achieved in almost all except 7%, and in-hospital mortality was 6% in gastric variceal bleed, versus if we compare in-hospital mortality of AKU, this was 2% in esophageal variceal bleed. So band ligation of regarding gastric varices, this is not recommended, though some studies have touched upon this issue. Only OGV1 can be helpful with band ligation, but OGV2 or isolated, we cannot band them. And there is a high recurrence of variceal bleed if we band them. Surgery may be indicated, but these are very sick patient at the time of presentation. Further decompensation happens when they have bleed, so it's almost reluctantly done. Spontaneous gastrorenal shunts are already there. So British Society of Gastroenterology suggests that surgery as a second-line therapy. This should not be considered as a first-line therapy. We should take this patient for emergent TIPS or even sometimes transplant if the facilities are available. So I'm seeing, at least in my practice, what happens, the person comes to with bleed, discharge on non-selective beta blocker, and gets admitted in other service, and they forget about continuing beta blocker. So this is very important to tell your residents who are consulting these patients that beta blocker should be initiated at the time of discharge, and the patient should be told that if there is no contraindication, there should be non-selective beta blocker should be continued. So meta-analysis is also showing that how about preventing first varicose bleed? Like there was no bleeding at all, but bleeding was never happened. So whether to go for band ligation or preventing with the non-selective beta blocker, that we use carvedilol. So this was the randomized control trial with Nazesh, myself at my institute, and AKU with Dr. Professor Hasnain Ali Shah, carvedilol versus esophageal band ligation in primary prophylaxis of varicose bleeding. What we concluded that there was no difference. Carvedilol was as effective as esophageal varicose ligation for the prevention of first varicose bleed, and in cirrhotic patient with no difference in mortality between carvedilol and varicose ligation group. This meta-analysis, this was recently published last year, to November of 2023 in Elementary Pharmacology, and so we were among the group of Bavino Corporation EASL Consortium, and so we concluded that in patient with compensated CLD, because now Bavino is saying specify them as compensated or compensated clinically preserved patients versus decompensated patients. So in patient with compensated CLD and high risk of varices on primary prophylaxis, non-selective beta blockers significantly improve survival versus endoscopic varicose ligation with no additional benefit noted adding varicose band ligation. Though in our clinical practice we are doing endoscopic band ligation and also using beta blocker. In compensated patients, survival was similar in both therapies. But what is different? The study suggests that non-selective beta blocker are preferable when advising preventing therapy in compensated cirrhosis. So compensated cirrhosis, there was no difference. But in decompensated cirrhosis, we should be doing both the things. There is another meta-analysis of carvedilol, which proved that this reduces the mortality and decompensation in patient with compensated cirrhosis. This was a competing meta-analysis we did with the same EASL group, Bavino Corporation EASL group, and this was 3 years back publication in Journal of Hepatology, which again is saying that the randomized control trial, there were 29 randomized control trials that were selected among 128, where comparing carvedilol versus control therapy, which may be no active therapy or esophageal varicose ligation, and in patients with cirrhosis and clinically significant portal hypertension without previous bleed. So they were never bleeding, and we used carvedilol in them. And the competing risk time analysis showed that the IPD that were obtained from principal investigators, the data was obtained from principal investigator, and primary outcome were prevention of decompensation and death. So we concluded that, and you can see the plots here, that non-selective beta blocker, preferably carvedilol, are indicated for varicose hemorrhage primary and secondary prophylaxis, and compensated advanced chronic liver disease values by liver stiffness measurement can be assessed non-invasively to plan a therapy. Sorry for this spelling mistake. Risk for decompensation and mortality can be decreased with carvedilol. So, sorry. So just to conclude, acute varicose bleed, vasoactive therapy and terlipressin or octreotide, whichever you use, and then we need to take measures for hemodynamic stability, start antibiotic, take them for endoscopy, and if in the majority of the time we are controlling, but if we fail, second attempt with endoscopy, no response, buy time with balloon tamponade, and fully covered metal stent tips or shunt surgery or emergency transplant may be used. Just 2 things. So just to conclude during this discussion, terlipressin versus octreotide, no difference, but yes, terlipressin has proved mortality benefit. Again, non-selective beta blocker, carvedilol has proved mortality and prevention of decompensation in compensated cirrhotic as a primary prophylaxis. So these are 2 major take-home points. Thank you very much.
Thank you, sir, for so comprehensive and elaborative talk on management of variceal bleed. So the next speaker of this session is Dr. Nasir Lak. He is Professor of Gastroenterology and Head of Department Gastroenterology and Hepatology Division SIUT. He has a lot of publication and research papers, including review articles and meta-analysis. He is also supervisor and examiner for gastroenterology at CPSP. He is going to talk on celiac disease, its diagnosis and management. Sir, please.
Uh, because it takes time for the presentation to come here, is some time lag. I can talk from the behalf of patients. My presentation would be a physician advocacy and a patient advocacy, because in my experience, we're really missing lots of patients of celiac disease, which we are not diagnosing. So this is one of the patient's history, that a 42 years old man who was seen by a gastroenterologist with specific transaminase anemia, which is a common problem nowadays. Everybody thinks that this is MASLD. And even his liver biopsy, viral serology, all sorts of things were carried out, but it turns out to be normal. Then ultimately the patient was diagnosed to have celiac disease. So it's an autoimmune phenomena, and it is a very unique disease which is specific to our, although the internists also diagnose it, the pediatricians are lots of patients they have as we have, but we should know that this disease exists in larger number. So what happens even in the advanced countries? This is a 1% disease. Every 1% among 100 people will have this disease, and it will be asymptomatic individuals running around, and the awareness has to be increased along with the testing. If we go historically, it was undiagnosed, and still it phenomena exist to majority of patients. And we know that because of the uncoding in America, you see there are lots of people which are not included, and it's a very recent phenomena. Now they change it to some extent. So the initial cost is high in those countries where this is not third-party payment. This is our local data. We do have local data. Somebody who presents with chronic diarrhea, there is 53% chance that the patient may have celiac disease. And in pediatric population, presenting with symptoms have 17 to 18% chances. Somebody who has iron deficiency anemia, when they were being followed, and more than 10% were diagnosed to have celiac disease. And in other studies, there are about 33% chances of somebody who is short stature, which was followed to have celiac disease. So if we go into the pathogenesis, so somebody who is exposed to gluten, then it is there in the environment, triggers their dysbiosis, and the chronic inflammation leads to villus atrophy, and the pathogenesis of gliadin fragments exposed to the mucosa can trigger a complex immunity, that is Th1, Th2 cells, and which can trigger lots of cytokine aberrance and can lead to damage. But what about the clinical presentation? Only the classical presentation of celiac disease, for which we are trained and tuned, is only in 27% of the patients, which includes diarrhea, weight loss, and malabsorption. But what about the rest of the patients who will not have symptoms? And for those who will have symptoms, which is not ingrained in our mind to have celiac disease, like constipation, anemia is very common, osteoporosis, which we underdiagnosed always, hypertransminasias as in my patient, neurological disorders, ataxia, dermatitis herpetiformis, we get referral from the dermatologist. So if we go about the intestinal form, we are little bit acquainted with this outcome, but what about the extra intestinal forms? The extra intestinal forms can be neurological, related to bone, endocrine, dermatological, oral and ocular, which we tend to miss. So this is our local data in which most of the patients of celiac disease were having anemia. And the author is here with us with this study. The most of the patients were not having any symptom. And if you go what to do by us as physicians, the classic celiac disease, okay, there is typical neuropathy and positive antibodies. We'll go about it in more discussion, but if you see the celiac iceberg, the latent celiac is more at the base, and the silent celiac is the second one. The symptomatic celiac is on the top, which is the tip of the iceberg. Seronegative celiacs are there. Slow responders we do see. A refractory celiac disease is regularly diagnosed, and gluten ataxia and dermatitis herpetiformis are the patients which we rarely see in our setups. Okay, what we have to really rule out? Gluten ingestion, there will be IBS-like symptoms, there may be extra intestinal manifestation. We have to rule out celiac disease, rule out wheat allergy as well. In both of the cases, it's quite confusing sometimes. This is one of the instances where we can start gluten-free diet for some time. The symptom resolves, yes. Then this is one of those patients in which we justify to give a gluten re-challenge. And if symptom returns, yes, non-celiac gluten sensitivity is confirmed. I'm showing the same Pakistani data, but when we have to do investigation, when even the celiac disease serology is negative. When there is chronic diarrhea, okay, we are doing it. Diarrhea of the features of malabsorption, iron deficiency anemia, in our studies, it has been already seen. GI symptoms, family history of celiac disease. The whole family has to be taken into consideration. GI symptoms in patient with autoimmune disease or IgA deficiency. We have been regularly following patients with autoimmune hepatitis who do have celiac disease as well. Then skin biopsy proven dermatitis herpetiformis. Patients with video capsule findings suggestive of villi atrophy, more in Western countries. And unexplained high output ileocolostomy. And we have diagnosed such patients. When celiac disease serology is indicated, biopsy is needed only when the serology is positive in patients who have been previously been labeled as IBS for many years. Elevated transaminases, microscopic colitis, Hashimoto's thyroiditis, and bone issues. If you see that coexistence of celiac and Crohn's in Pakistan has been diagnosed regularly. Early non-infective celiac disease associated with microscopic colitis and splenomegaly, we have published it. And non-alcoholic fatty liver disease in young male with celiac disease, as well as a lean NASH, what we used to call at that time. Celiac disease with multiple immunodeficiencies, yes, it is there. So intestinal spirochetes in a patient with celiac disease. So we have a case series of intestinal spirochetes. So celiac disease is an unusual cause of dysphagia. Do we need to follow them up? for celiac disease. Okay, how do we diagnose? There's high probability when there is symptomatic patient and the patient comes to us. Duodenal biopsy and TTG IgA is done. If both of these things are negative, then celiac disease becomes unlikely. When both of these test criteria, the serology and the biopsy, then celiac disease is diagnosed. But what to do with the other part, which is low probability patients? And there is a lot of overlap. There may be IgA deficiency issues. There may be seronegative celiac disease going on. Then we have to include DGP, and we have to think more intelligently. And HLA-DQ2 and DQ8 genotyping has to be incorporated in certain patients. The sensitivity and specificity is fairly good, and the advantages are multi-pronged. But we need to know, and we need to teach our students as well, that the classification is very specific and it has clinical implications. The biopsies has to be taken in typical pattern, and it has to be always like what is needed. And the histopathology has to be read in a sequence, in a more stringent manner, and the intra epithelial lymphocytes has to be calculated, and the report has to be very specific. The non-specific reports do more damage, and we see it as a daily business. The confounders are to be ruled out, especially in our area. Giardia lamblia is very, very common in big cities. So what are the indications for HLA typing? Because we were the one doing for the last 3 decades. A negative HLA test is helpful to exclude the possibility of celiac disease. It has to be very clear in our mind. This is especially helpful on those already on gluten-free diet before testing, because when we are more famous and when we have more patients and when we are more available to the patient, then we have empiric therapies. And lifelong gluten-free without evidence is a little more than what we should do. When diagnosis of celiac disease is uncertain, yes, then it is justified to distinguish siblings who might have seronegative celiac going on. Even symptomatic patients do have this problem. In patients with other autoimmune diseases and some genetic disorders who should be investigated, like autoimmune hepatitis, who have problem microscopic colitis with seronegative celiac disease. So this was a good paper, the clinical pathological study of seronegative celiac disease in adults in Pakistan. So there is a long list of differential diagnoses. I think so a gastroenterologist can do justice with these differential diagnoses. And there is normal villus architecture, increase intraepithelial lymphocytes. So this is a very, very common phenomena. When you used to go to the histopathology yourself, sit with them and see the slide with your own eyes, and you will be astonished to see this phenomena, which is very common in Pakistani population. There may be food hypersensitivities, which goes undiagnosed because we don't have means to diagnose it. H. pylori associated problems, which are very common. Drugs, infections. We don't diagnose cryptosporidium that common. You have to take extra pain to stay in it and see it, the slide. Immune dysregulations is going on. The rheumatologists are in contact with you. The dermatologists are in contact with you. Then are the rare things: bacterial overgrowth, blind loop syndromes, and microscopic colitis. Microscopic colitis again goes undiagnosed in our settings. IBS. This is one of the very common presentation of IBS. You will see lots of increase intraepithelial lymphocytes. And when it is associated with villus atrophy, plus minus increase intraepithelial lymphocytes, yes, there are many infections. I just already mentioned giardia. Whipple's disease, although uncommon, very uncommon, we have published case series in our renal transplant patients. And collagenous sprue, yes, it is there. Autoimmune enteropathy, and rest of the rare causes had to be ruled out. When there is a clinical suspicion, the normal diet, the patient is taking normal diet, the TTG is positive, the biopsy is carried out, it is classified, and celiac disease is diagnosed. So we reach this place. When the biopsy is normal with positive serology, there's a potential celiac. In children, the pediatrician do the endomycin antibodies, they diagnose celiac disease. Okay, fair enough. When it is the serology is negative, the IgA deficiency, then we have to take the biopsy and we can label somebody seronegative celiac. The other enteropathies has to be ruled out, especially very important, and this is a message today that the tropical sprue exists in Pakistan. We are in tropics. So our patients, the big confounder with celiac disease in our setting, especially in where we work, is tropical sprue. And if we go, somebody is already taking gluten-free diet, and the HLA DQ2, DQ8 is negative, then we are comfortable that there is no possibility of celiac disease in this cohort of patients. But if it is positive, then this is the proposed mechanism that we go through the gluten challenge and see what is the outcome. And it has already been studied, the amount of gluten which has to be taken into consideration. And then this is a very new phenomenon that after challenge of gluten, you can do the TTG, the titers can rise. And TTG has to be seen with the titers in somebody who is on gluten-free diet. So what is the problem which we are facing at the moment? The gluten-free diet, we have limited options. Our social fabric is very specific. We all rely on gluten for our staple diet. And these are the options. I think so, apart from because in Sindh, there is a culture that they can make bread out of rice. So they can take that. But in other provinces, wheat is the issue. So the benefits are, one can be saved from upcoming tumors, morbidity, and mortality if somebody sticks to the gluten-free diet, and it has to be taken with lots of repeated interviews with the patients, giving them the options that everything is they can take that in terms of fruit, in terms of meat, dairy products, and all sorts of things, but not wheat and the other less available gluten intakes. So the approach will be a regular follow-up, and initially it has to be more. Within a year, a repeated follow-up is needed with reinforced repeated dietary advices. So non-responsive celiac may be a late responders. We have to confirm the accuracy of celiac disease diagnosis. Yes, it is there. Adjust the diet, monitor the patient, and if there's a doubt, the small bowel biopsies, the colonic biopsies, if there is persistent diarrhea, to rule out other possibilities, microscopic colitis. The confirmation of this disease is not there. They exclude other causes. And the supporting evidence are there, lots of data available. And enteritis with villus atrophy, yes, then we have to rule out the possibility of refractory celiac. And if there is no enteritis and there is no villus atrophy, then consider alternate etiologies. Refractory celiac, yes, this is a reality and with bad outcome, and one has to diagnose that it is existing in subgroup of celiacs. Then the celiac crisis, a very challenging clinical issue in which the patients they have high mortality. The emerging therapies, yes, there are enzymes therapies, there are gut barrier protections available. TG2 inhibitors are available now. HLA DQ blockage, I think everybody thinks a low success rate, but there are drugs now available, and immune tolerance inductions are the possibilities which we can have. Why people can't stick to gluten-free? It is high cost, it's not available, and it is all there that we see the hidden gluten in our diet, and why the patient is late to be diagnosed. I know certain gastroenterologists, consultant gastroenterologists, they have celiac disease. They become gastroenterologists because they had celiac disease. So it is a disease with poor prognosis once we miss. Thank you.
Thank you, sir, for so amazing presentation on celiac disease, its diagnosis and management. So let's move to the next speaker. So next speaker of this session is Dr. Dawood Gelzai. He's assistant professor of gastroenterology division, Bolan Medical College, Quetta. Yeah. Should I move? Okay. The next speaker of this session is Dr. Dawood Gilzai. He is assistant professor of gastroenterology, GI division, Bolan Medical College, Quetta. He is also general secretary, Pakistan Society of Hepatology, and vice president, Pakistan Society of Gastroenterology and GI endoscopy. He is going to speak on management of intestinal tuberculosis in developing countries. Sir, please.
Assalamu alaikum. Thanks to the organizer, Dr. Sherry Rahman, Dr. Kamran, and Dr. Jadoon for inviting me to talk on important topic in gastroenterology. My topic of presentation is intestinal tuberculosis management in developing countries. I have no disclosure regarding this presentation. The key facts regarding abdominal tuberculosis: it was first recognized in the spinal column of an Egyptian mummy in 30,000 BC. The facts about TB, a global arena about TB. The first drug to kill TB bacteria was streptomycin, and the first oral anti-TB drug developed was rifampicin. WHO declared tuberculosis as a global emergency, and WHO promoted DOTS strategy in 1995 and NTB strategy in 1916. TB is a diagnostic dilemma, and Joseph Wash' famous quote was, diagnosing abdominal tuberculosis was impossible with any degree of certainty, since the disease mimic many other abdominal conditions and histological confirmation may be equivocal. Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis and also known as Koch's bacillus. It's generally infect the lungs, but it can cause infection in other parts of the body, in which case it is called extrapulmonary tuberculosis. How tuberculosis infect intestinal tract? It is by ingestion of unpasteurized milk, ingestion of infected sputum, lymphatic spread from infected lymph nodes, hematogenous spread from primary lung focus, primary TB or other organ, or maybe from other organ to the intestine. The epidemiology of tuberculosis, it is the 13th leading cause of death worldwide. Tuberculosis is the second leading infectious killer after COVID-19. 10 million cases of tuberculosis was found worldwide in 2020, and there were 1.5 million people died from tuberculosis. Quarter of the world population has latent TB, and extrapulmonary tuberculosis is about 20%, in which intestinal TB is about 10%. The intestinal tuberculosis is the sixth most prevalent presentation of extrapulmonary tuberculosis, accounting for 1 in 5 registered TB patient. In Pakistan, abdominal tuberculosis remains one of the most common extrapulmonary cases. In Balochistan, in 2014, the 51 cases of abdominal tuberculosis was registered, and from 1st January till April, 19 cases were registered with abdominal tuberculosis. Estimated incident of TB cases in 2022, the at least 100,000 incident cases were found. We are 5th in the most prevalent countries. Other countries are China, Bangladesh, Philippines, India, Indonesia, Dominican Republic of Congo, and Nigeria. The incidence of TB in 2022 per 100,000 population per year in Pakistan, it is 250 cases per year. The risk factor, generally TB occurs in the most populated areas with low socioeconomic status and poor sanitation, and the other risk factor occur in immunocompromised patient, individual having tuberculosis, diabetes, alcoholism, and illicit drug abuse, cirrhosis, and stage liver disease. The ileocecal, the TB generally infect intestinal tract, the ileocecal region, which is about 80 to 85%. It is because of abundance of lymphatics, physiological stasis, narrowing, and minimal digestive activity. There are 4 major forms of intestinal tuberculosis. The most common is ulcerative one, in which superficial, circumferential, transverse ulcer occur. And the second form is hypertrophic. This form occurs as a hypertrophic reaction around the ulcer. It's mainly occur in the untreated patient. And the ulcerative hypertrophic form, which is the combination of ulcerative and hypertrophic form. Clinical manifestation of abdominal tuberculosis vary greatly and are not specific, also depend on the area of involvement. This makes it difficult to distinguish intestinal tuberculosis from other intestinal disorders. These are the common symptoms which occur from different studies. Abdominal pain, weight loss, fever, anemia occur in 75, 64, 40, 44, and 55% of cases simultaneously. Laboratory tests to diagnose abdominal tuberculosis infection is tuberculin skin test, recommended in clinical work with children under 5 years of age, where a positive test is more likely to reflect recent infection, and it is not expensive, required 2 visits of patients, and require expertise for intradermal injection. Results are available within 48 to 72 hours, and adequately trained staffs are required to do this test. No special laboratory infrastructure or supplies are required. BCG vaccination may cause false positive results in younger persons. IGRA interferon based gamma release assay, which replaces tuberculin skin testing. And IGRA was designed to replace TST in the diagnosis of latent TB and were not intended for diagnosis of active tuberculosis. IGRA should not be used in low and middle economic countries for the diagnosis of pulmonary or extrapulmonary tuberculosis in adult, the diagnosis of latent TB infection in children. Laboratory tests that are not recommended for TB diagnosis. These are serological tests, commercial serological test, that is TB dot, is inconsistent and imprecise finding results in highly variable value or sensitivity and specificity. No evidence that existing commercial serological assays improves patient important outcome in high proportions of false positive and false negative results adversely impact patient safety. Other tests that are not recommended are blood CBC and ESR, because anemia is more likely to be due to other causes than TB, and WBC is usually normal or may be low in tuberculosis. ESR is usually raised in TB, but in other condition too, and normal result, however, does not include active TB. It is strongly recommended that these tests not be used for the diagnosis of pulmonary and extrapulmonary tuberculosis by WHO. The advantages of tuberculin skin test and IGRA. Tuberculin skin test can be performed in field. No laboratory setup is required, and it is of low cost. IGRA is a single visit test, and result possible within 24 hours, and no false positive results due to BCG vaccine. TB diagnostic tools. We use these tests to diagnose TB infection. These are for bacterial diagnosis. We do Gene Expert, MTB RIFSA, MTB XDR assay, and line probe assay. These are genotypic tests, and we also do smear microscopy with ZN staining and fluorescence. We do culture and sensitivity, which is a phenotypic test on tissue samples. Clinical diagnosis is by histopathology, patient history and symptoms. Radiology and can be done to diagnose intestinal TB. TB infection is latent TB is by tuberculin skin test, and IGRA can be used for latent TB, but not for the diagnosis of TB infection. Non-specific tests are serology, that is TB dot, and blood CBC and ESR. Diagnostic test for bacterial confirmations are AFB microscopy, which is already said that ZN staining and fluorescence microscopy is done, which has low sensitivity, and false positive results are more likely to occur. The other microscopic test is bacterial culture, which is solid and liquid based, and is a gold standard for tuberculosis. Other test is molecular testing, which is Gene Expert. It is a real-time PCR done test, and the sensitivity and specificity of Gene Expert is very high, that false positive results may occur. Histopathology, we can do biopsy of a cecum, terminal ileum for histopathology, and the depth, number of tissue, volume of tissue, and number of biopsies will influence the results. At least we do 8 to 10 biopsy for the good results. Combination of histopathological examination with mycotuberculous culture. The combination of these two will increase diagnostic accuracy by 17%. Several studies reported a comparison of combined histological examination with TB culture in regard to culture medium LJ and Bactec medium. Bactec is the recently used culture medium. From these studies, we concluded that Bactec medium has better diagnostic value compared to LJ medium in a scenario of combined histological examination and culture. PCR testing, the sensitivity of PCR testing is very high, but sensitivity is very low. But negative PCR will not exclude intestinal tuberculosis. Multiplex PCR, the difference between multiplex PCR and simple PCR is that simple PCR only amplifies one gene sequences, while multiplex PCR can detect many gene sequences that are bacteria specific and has lower false negative results. Imaging studies, CT scan is the modality of choice in which we can see irregular structure or thickening, mass, and necrotic lymph nodes. Magnetic resonance imaging cannot detect small calcification within the nodes or mass and is not helpful for distinguishing between Crohn's disease and intestinal tuberculosis. A negative chest X-ray does not exclude intestinal tuberculosis. Gastroenterology procedure colonoscopy may detect asymptomatic cases when performed for other reasons. Finding or colonoscopy may be stricture, ulcers, deformed cecum, and ileocecal wall. Biopsy obtained by colonoscopy have been reported to have as high as 80% diagnostic accuracy. The yield from culture has been reported to be higher than multiple tissue biopsies are obtained during colonoscopy, at least 8 to 10 biopsy per specimen. Endoscopic ultrasonography can help with the imaging of various lesions close to gastrointestinal lumen, and they can also be aspirated or biopsied using EUS guided 5-needle aspiration or biopsy. The differential diagnoses are divided according to the types of intestinal lesion, and the Crohn's disease is the only granulomatous disease that can share all form of abdominal tuberculosis. The difference between intestinal tuberculosis and Crohn's disease, in Crohn's disease there are linear ulcer, gobble stoning, and stricture, and in tuberculosis there are circumferential, superficial, transverse ulcers, and also it is a stricturing disease. These are the difference between Crohn's disease and Crohn's disease and tuberculosis. Tuberculosis is a continuous course, but Crohn's disease has a remitting and relapsing course. In tuberculosis, there is high swinging fever, but fever may occur in Crohn's. And the ulcers, which I already said, is transverse in tuberculosis, but in Crohn's disease, it is linear ulcer. And the skip lesions can occur in both disease, and stricture may occur in both disease. Endoscopic feature is already mentioned, and these are also the difference between Crohn's disease and intestinal tuberculosis. This is the flow chart when we find an ulcerative lesion on endoscopy with no caseating granuloma or AFB on tissue biopsy. We will go for clinical and endoscopic assessment and chest radiography. If these are negative, then intestinal TB is unlikely. We will treat it as a Crohn's disease. If there is suspicion of intestinal TB, the other tests like culture, PCR, gene expert are performed. If intestinal TB is confirmed, we will treat as an intestinal TB. If the tests are negative for intestinal tuberculosis, then we will treat as a Crohn's disease. Treatment on intestinal tuberculosis are medical, endoscopic, and surgical. We have 6 months of therapy for intestinal tuberculosis, 2 months of continuous, and 4 months of consolidation phase. No more than 6 months treatment are required because of the side effects and low complaints of patient. The anti-tuberculous drugs, first-line drugs are isoniazid, rifampicin, pyrazinamide, ethambutol, rifabutin, and rifapentine. The second-line drugs are streptomycin, cycloserine, aminosalicylic acid, ethionamide, imicacine or kinamycin, cipromycin, levofloxacin, moxifloxacin, and getafloxacin. WHO grouped all these drugs into 5 groups. The duration of treatment, as already mentioned, that for intestinal TB we use 6-month therapy. No more than 6-month therapy has beneficial than 6-month therapy is beneficial than 6 months because of the side effects and low complaints of patients. Hepatotoxicity may be caused by isoniazid, rifampicin, and pyrazinamide. Drug-induced hepatitis may be asymptomatic or symptomatic. Symptomatic patient or serum AST level of 5 times more than the upper limit of normal. Symptomatic patient most commonly present with abdominal pain, nausea, vomiting, as AST of 3 times and upper limit of normal. If a patient present to the emergency department with significant elevation of AST, the medication should be discontinued. These are symptoms of patient with TB drug side effects, which are jaundice, fatigue, abdominal pain, and nausea. Monitoring for drug-induced hepatotoxicity and drug-induced liver injury. We will do baseline LFTs to check the elevation and rule out acute viral hepatitis. Repeat hepatic enzyme every 2 weeks for the first 3 months, and then monthly are recommended in the following situation. Antibacterial resistance, drug resistance, intestinal TB, when Mycobacterium tuberculosis complex grown on culture of intestinal biopsy showed resistant to any of the first-line drugs, first or second-line anti-TB drugs. Multi-drug resistance occurs when it is resistant at least to rifampicin and isoniazid. Extensive drug resistance occur when it is resistant to isoniazid, rifampicin plus fluoroquinolone and at least one of the 3 injectable second-line drugs, that is imicacine, kinamycin, and cipromycin. Empirical treatment, empirical anti-tuberculous drug treatment is for 2 to 3 months and may be considered appropriate in countries with high prevalence of abdominal tuberculosis, and if the clinical features are compatible, that is, the clinical, radiographic, and endoscopic data are consistent with the diagnosis of abdominal TB, and if other common diseases such as cancer, non-specific inflammatory bowel disease, and other specific infection can be adequately ruled out. Endoscopic intervention, we can do balloon dilatation for ileal and duodenal strictures. Surgical treatment for acute abdomen emergency surgery could be done, and intestinal, which is ulcerative stricture or hypertrophic, for ulcerative anti-TB treatment, and for stricture, stricturoplasty and resection can be done. For hypertrophic disease, resection can be done. These are surgical treatment options. Complication, the upper and lower GI bleeding, fistula occurring at different sites, obstruction and gastrointestinal lumen, stricture formation, intussusception, perforation, anemia, malnutrition, and malabsorption are the complications. Patient education and public awareness on intestinal tuberculosis is important. Educate the patient about the disease and emphasize the importance of adherence to treatment, provide information on symptoms, and discuss prevention measures. offer support and resource. Public awareness: intestinal TB is a serious but treatable disease. Don't delay seeking medical attention if you have persistent abdominal pain, weight loss, or other unexplained symptoms. Early diagnosis and treatment are crucial. TB is not contagious through casual contact. It is spread through respiratory droplets, and adherence to treatment is essential for a successful outcome. Resources are local health facilities, national TB program, and community health workers. These are the references from where I and thank you.
Thank you, sir, for so detailed talk on intestinal tuberculosis. So the next speaker of this session is Dr. Nazish Bhatt. She is Associate Professor of Gastroenterology and Head of Department, Jana Postgraduate Medical Center, Karachi. She is also Supervisor and Examiner for Gastroenterology at CPSP. She has multiple publications and research papers on national and international level. Additionally, she is also General Secretary of PSG, member of WGO Endoscopy and Clinical Research Committee. She has also achieved ACG International Award for the awareness of colorectal carcinoma. She is going to speak on the management updates on IBS. Ma'am, please.
Assalamualaikum and good morning. थैंक्स गॉड कि कुछ हॉल के अंदर लोग आ गए, वरना मुझे लग रहा था कि बस मैंने जो है डॉक्टर काशिफ को पढ़ाना है और डॉक्टर नासिर लक को पढ़ाना है और बस. So today I'm going to discuss about the irritable bowel syndrome. What are the new updates in the management? So we all know it's a very boring topic, but in our OPDs we almost seen around more than 70%. I think more than 70% of the patient in private clinics are presented with IBS. So what is IBS? How many of you agree with this? Gas दिमाग पे चढ़ जाती है. Just raise your hands. I will prove in the end. So irritable bowel syndrome is an extremely common and often very debilitating chronic functional gastrointestinal disorder. Despite its prevalence, significant associated healthcare cost and quality of life issues for affected individuals, our understanding of its etiology remained limited. मेरे अपने रेजिडेंट्स जो हैं वो आए दिन छुट्टियां कर रहे होते हैं, कभी उनको डायरिया हो रहा है, कभी क्या है, और वो एक दिन में सेटल भी हो जाता है. तो हेल्थ केयर कॉस्ट, क्वालिटी ऑफ लाइफ, इट्स वेरी इंपॉर्टेंट. So yesterday we have observed World IBS Day. April 19 was observed worldwide as a World IBS Day. So irritable bowel syndrome is a long-lasting, relapsing disorder characterized by abdominal pain, discomfort, and altered bowel habits. Intestinal motility, impairment, and visceral hypersensitivity are the key factors among its multifactorial pathogenesis, both of which require effective treatment. So most of the patients presented to us with the complaints of cramping, abdominal pain, gas. पूरे पाकिस्तान में सुई गैस कम है, बट सबके पेट में बहुत ज़्यादा गैस है. Gas, diarrhea or constipation or both. So what are the earliest descriptions of IBS? So it's not very new disease, it's an old disease. In 1849, W. Cumming, the bowels are at one time constipated, at another legs in the same person. How the disease has two such different symptoms, I do not profess to explain. There are some historical terms: mucus colitis, colonic spasm, neurogenic mucus colitis, irritable colon, unstable colon, spastic colon, nervous colitis, spastic colitis. In 1962, Dr. Chaudhary and True Love coined this term, irritable colon syndrome. How many of you know who is Dr. Chaudhary? Anyone? Anyone from Karachi? Dr. Chaudhary was, I think, the first principal of Sindh Medical College, Karachi. 1966, C.J. Diller, irritable bowel syndrome. So this term came into the existence in 1966 by C.J. Diller. So there is again evolution of mechanistic hypothesis in IBS. Initially, you think there is abnormal motility, then there is visceral hypersensitivity, then there is brain-gut interaction. We all know कि जो गैस है वो चली जाती है ऊपर. Then there is 5-HT mediated visceral sensitivity and gut motility. So these are all new concepts now, the gut-brain axis. So what is gut-brain axis? It's a vicious cycle. And there are three main key players in this: the vagus nerve, the bloodstream, and the hormones. So in our brain, so the brain possesses the largest amount of neurons with 80 to 100 billion of them. That is 200 times more than in the gut. So there is 100 billion neurons. So, and in the gut, with 200 to 600 million neurons, the gut is referred to as the second brain. So this is very important. So all the communication between the gut and brain, 80% occurs through this, the vagus nerve, which is the fastest communication channel between the gut and the brain. And the rest, 20%, occurs with the other hormones which are present in the neurotransmitter in the gut. So in the balanced emotional state, normal functioning brain, stress management and mood balance is very important for the healthy gut. So when all this system is under control, so there is maintenance of gut barrier integrity, and there is no external triggers which leads to these symptoms. So it's very important. Mental relaxation or normal functioning of the brain is very important for the healthy gut. So what happens? If there is psychological trauma, emotional distress, chronic anxiety, it leads to sensitized brain, anxious mind, an altered brain, pain region, stress hormones, cortisol and CRF release, which leads to gut permeability, leaky gut. Gut immune response, knotted belly, excess of immunity, there are different factors production, which leads to all the symptoms of this irritable bowel syndrome. Excavation of the gut permeability, irritated gut, stress-induced gut permeability. एग्ज़ाम्स के अंदर अक्सर बच्चे पेपर को देख के फ़ौरन वॉशरूम चले जाते हैं. इंटरव्यू हो रहा है, इंटरव्यू छोड़ के वॉशरूम चले जाते हैं. तो why this happens? This is all due to this anxiety, stress and distress, which leads to the exacerbation of gut permeability. Hypersensitized gut, angry gut, abdominal pain, cramps, bloating, diarrhea, all this happens when your mental function is not correct, or you are in some stress or emotional trauma. And your visceral sensitivity is also increased. You started feeling pain. So there is a strong association of gut-brain axis in all these symptoms of irritable bowel syndrome, because it influences the neurotransmitters, stress, anxiety, mood behavior. They influence the motility, secretion, nutrient delivery, microbial balance. So what happens with the stress? There is brain gut dysregulation. There is altered motility of the intestine, which leads to altered gastrointestinal microbiome, which leads to increased transient infections, altered endocrine metabolism, serotonin, neuronal plasticity. And some people are prone to develop this symptom due to genetic polymorphisms. And this all stress even leads to bile acid malabsorption. So what is the impact of IBS on daily routine life? 70% of IBS patients have abdominal pain or discomfort, significantly affecting their quality of life. जब हम लोग आगा खान में रेजिडेंट थे तो हमारा एटिक में एक रूम होता था, आतिफ इधर बैठा हुआ है, उस रूम में हर वक्त जो है वो सिरप और फ्लैजिल की टैबलेट्स पड़ी होती थी और मैं परेशान होती थी, क्या कहें, सब के सब यही खाते रहते थे कॉल्स पे. IBS patient complaints severely damaging their quality of life are as follows: their abdominal pain and discomfort, abdominal fullness, constipation, diarrhea, incomplete evacuation. This is very important. Patient आपके पास आके बोलता है कि मैं constipated हूँ, but he is passing stools daily. So this is incomplete evacuation. Mucus with stools, staining at stool, epigastric pain, and milk intolerance is also seen in these patients. For the diagnosis of IBS, it is very important to make a positive diagnosis. Identify abdominal pain as dominant symptom with altered bowel function. Look for the red flags. So, Dr. Nasir presented very well about the celiac disease, so you have to rule out celiac disease. Daud presented about the intestinal TB in Pakistan, you have to rule out intestinal TB in your patient. Then lactose intolerance. So there are many diseases, and you have to look for the red flags like anemia, bleeding per rectum, weight loss, family history of colorectal cancer, or any other GI malignancy. So you have to rule out. So make a confirmed diagnosis. ये नहीं कि पेशेंट आया आपने उसको कहा तुम्हें IBS है. You have to make a confirmed diagnosis. Initiate treatment program is a part of diagnostic approach. Follow up in 3 to 6 weeks. So what is Rome 4 criteria? So recurrent abdominal pain for more than or equals to 1 day per week in last 3 months, associated with more than or 2 of symptoms like defecation, change in stool frequency, form, symptom onset more than or equals to 6 months prior to diagnosis. So this is the very simple Rome 4 criteria, but you have to rule out red flags. Then we have IBS subclassifications. So we have IBS with diarrhea predominant, in which patient have loose stools in more than 25% of the time and hard stool less than 25% of the time, and it is in up to 1/3 of the cases, more common in men. IBS with constipation predominant is more common in the women. Then we have a mixed type in which sometimes patients said मुझे diarrhea होता है and sometimes constipation. Then we have unsubtype IBS also. Insufficient abnormality of the stool consistency to meet the criteria of IBC or M. वो आपको डिस्क्राइब ही नहीं कर पाएगा कि स्टूल कैसा आता है. So IBS subclassification on clinical grounds. So IBS with predominant bowel dysfunction, IBS with predominant pain, IBS with predominant bloating. Then based on the precipitating factors, like post-infections, very common. After the enteric fever or severe gastroenteritis, they develop IBS. Food-induced, meal-induced, and now last but not the least, stress-induced, stress-related. So what is the current management of the IBS? Establish a positive diagnosis. Reassure. Reassurance is very important. That reassurance to the patient that there is no serious organic disease or alarming symptoms. Success of current treatment options in addressing multiple symptoms of IBS has been limited. So you have to tailor the therapy according to your patient's symptoms. Either he or she has IBS-D, IBS-C, abdominal pain, or bloating. So what are the steps of the IBS management? Education, very important. Reassurance, dietary modification, use of fiber, symptomatic treatment, psychological, behavioral options, and make some realistic goals. Traditional diet advice, regular meals, good hydration, low food map diet, which is evidence-based for symptom relief, and it is very common practice in UK. Avoid gas-producing foods, caffeine, alcohol, gradual fiber adjustment based on your symptoms. So what are the currently available treatment options for IBS? We have dicyclomine, hyoscyamine sulfate, and anticholinergics and sedatives. Clydinium bromide with chlorodiazepoxide is very common drug used in Pakistan. Almost every IBS patient is using this drug. Allocitron was introduced, but now it's withdrawn from the market because it has some side effects. Rifaximin. Rifaximin is a very promising drug which is used for the management of the IBS diarrhea predominant. And the beauty of this drug is it's an oral, non-systemic, broad-spectrum antibiotic that targets the gut and is associated with low risk of bacterial resistance. So you can use these drugs multiple times in your patient. So when we were in the residency, this trial was rifampicin published in NEJM. So they have given the treatment 550 milligram of rifaximin for 14 days to the patients of IBS diarrhea predominant. So they got relief for 6 months. पाकिस्तान में ये है कि आप इसको 550 मिलीग्राम जब देते हैं तो लोग कहते हैं गरम दवा है, तो आपको ये पेशेंट को ये भी समझाना है कि इट एक्ट्स लोकली, तो ये गरम दवा नहीं है. Then you can give antispasmodics according to the symptom of your patient, like mevaverine hydrochloride, smooth muscle relaxants, according to your patient's symptoms. So you have to tailor the therapy. Then you can give the antidiarrheals, which increase the stool firmness, decrease stool frequency. So there are various options available. Laxative and bulking agents for the symptomatic relief and for constipation. Increased dietary fiber or psyllium, osmotic laxatives, stimulant laxatives, and some laxatives and bulking agents can exacerbate abdominal pain and bloating, like lactulose. They lead to bloating, and it also causes gas retention. So you have to be very cautious about giving the drugs to your patients. Tricyclic antidepressant and SSRI. So there are many now research articles available in which they have proved that tricyclic antidepressant and SSRI have a very good role in the management of the IBS, because we have seen most of our patients develop IBS, some psychological trauma or stress or anxiety. So it's very important. Again, in these patients, you have to tailor the therapy according to your patient demands and needs. So now, the question: what is the forbidden human organ? Forbidden human organ. Can anybody name? Forbidden organ of human. Colon? Anyone else? कुछ भी बोल दें भाई, एग्जाम थोड़ी हो रहा है. Forbidden organ? Human microbiome. So the human microbiome, I am giving you a very good theory, you have to understand this. The human microbiome came into this world before us and survived after us. हमसे पहले दुनिया में आया, हमारे बाद दुनिया से हम जाएंगे, तब भी हमारे पास हम ये होगा. So is this world for them or for us? So what is the role of microbiome in IBS? This is the forbidden organ. So we all know what is intestinal microbiota, and most of the diseases, now every disease occurs when there is a disbalance or dysbiosis between the good bacteria and the bad bacteria. So what is microbial differences in IBS? अब आपको गैस का concept समझ आएगा. So IBS diarrhea predominant IBS is associated with small intestinal bacterial overgrowth, which can be diagnosed by a positive hydrogen test. And the constipation predominant IBS-C is associated with increased level of methanogenic archaea, which can be diagnosed by a positive methane breath test. Now you can understand गैस जो है वो ब्रेन में कैसे जा रही है. So World Gastroenterology Organization in their clinical practice guidelines recommended the use of probiotics, which is a good bacteria, for the eradication of Helicobacter, inflammatory bowel disease, irritable bowel syndrome, necrotizing enterocolitis, and now the probiotics used in almost many diseases. And now they are in the new research, there is mood-changing bacteria as well. So what are the future therapies for IBS? Probiotics, bioactive components produced by beneficial bacteria via fermentation. Then there is stem cell-based gut on a chip. IPC is used to create personalized gut on chip for IBS patient. Enables testing of efficacy for new therapeutics. Then we have para-probiotics. Inactivated probiotics may stimulate cellular immune response, cell wall components. Then we have customized probiotic cocktails, which contain bacteria, fungi, archaeobacteria to address individual deficiencies or dysbiosis. Then we have precision antimicrobials, stem-specific targeted antimicrobial peptides, which is contractile nanotubes, and nanoparticles. Then we have bacteriophage therapy, selective against specific bacteria, improved dysbiosis in IBS. So this is the future therapies, all based on good bacteria and all the microbiome. The future therapy for IBS is microbiome therapy. Thank you.
Thank you, ma'am, for explaining the IBS in very simple words. So IBS is really a complex disease, rather a syndrome. There should be a separate fellowship in this disease. This was on the note. So let's move to the next speaker. The last but not the least speaker of this session is Dr. Akif Dilshad. He is Professor of Gastroenterology and Head of Department GI Division, Lahore General Hospital, Lahore. He is going to talk on endoscopic management of lower GI bleed.
Bismillah ar-Rahman ar-Rahim. I'm thankful to the organizers for inviting me for this talk. We are going to talk about endoscopic management of lower GI bleed. So this is our, we'll talk about upper, middle and lower GI bleed causes, then the tools used for the management, and then the specific endoscopic management of common lower GI causes. So classically, the bleeding distal to a ligament of Treats is defined as lower GI bleed, but more and more guidelines are now dividing it from the ligament of Treats to the ileocecal valve as middle GI bleed, and from the ileocecal valve to the anal canal as the lower GI bleed. So for the purpose of this presentation, we'll be taking the previous old gold definition. So 20 to 30% of the major GI bleeds are due to the lower GI bleeds, and a large majority of them arises from the large gut, that is 80 to 85%. Less than 10% are from the small bowel. These are the common causes, and these can be grouped as anatomical, vascular, inflammatory, and neoplastic. These are the endoscopic techniques that are commonly used for hemostasis, that is epinephrine injection, thermal contact or non-contact bleeding, coagulation, and then the mechanical therapy in the form of clefts or band ligation, and last but not the least are the topical hemostatic agents. So these are the tools for hemostasis that we are going to discuss one by one. First of all, this is a small gadget cap. It is very helpful in achieving the difficult access areas and applying the clips in certain areas where one may not get the access without the cap. Then the old gold epinephrine injection, we all use at the bleeding site, 4 quadrants, 1 in 10,000. And through the channel needle is used depending upon the gauge, 21, 23 or 25 gauge. It causes local vasoconstriction and tamponade. However, it is not to be used as a single agent. That has to be coupled with another therapy. So the other available therapies are thermal coagulation, non-contact is the argon plasma coagulation, whereby a high voltage spark is generated at the tip of the catheter, which ionizes the argon gas and generates a plasma layer and causes tissue surface coagulation. This is the hardware for argon plasma coagulation. It is important to note that we have got this catheter, and there are 3 different ports for this. One, it could be a straight firing APC catheter, it could be a side firing APC catheter, it could be a circumferential firing. So it is important that which catheter are you using, and you have to target it accordingly. The common settings for APC is when you use the right side of the colon or duodenum, you use lower current settings, that is 25 to 30, and when it is their stomach, you can use 40 to 60. And the flow of gas is 0.8 liters per minute. And you apply it in short bursts of 0.5 to 2 seconds only, with maintaining a distance of 0.5 to 1 millimeter. You first touch the target and then just withdraw it so that you can maintain the safe distance. Then the contact thermal coagulation, these can be again heater probe, unipolar previously used, and now more frequently used bipolar gold probe. This is the hardware for gold probe. Again, gold probe, you can see the tip is gold plated, and these are also again injection mounted and simple. With injection mounted, you have got a needle, as you can see in the last picture. So a needle can be used so that you can inject it simultaneously, followed by coagulation. The current setting for colonic bleeds are 10 to 15, and the duration of contact should be longer, that is 8 to... Acha, acha. Clonic bleeds for 10 to 15 watts and duration of contact is longer, and this has to be a coaptive contact, that you don't have to just touch it, you have to give a firm pressure to make it more effective, so that the blood flow is stopped, and then give it a good 8 to 10 seconds rather than 0.5 to 2 seconds in APC. So mechanical therapies can be in the form of hemoclips. We all use through the scope clips and over the scope clips. These are of variable jaw size depending upon the area you are using. And you can use the remountable or reusable the Olympus remountable clips. And over the scope clips are expensive but are available. So the form of mechanical therapy is band ligation. You can use the six shooter on the scope, or rectal band ligation can be done using the rectal gun. These are the topical agents. These are used generally where there is diffuse bleeding and the areas where sutures or cautery are not ideal and conventional hemostasis is inadequate. The most common cause of lower GI bleed is divertical bleed, reaching up to 40% of the total causes. It is generally a self-limiting bleed and mortality is less than 5%. The common bleeding site are usually from the neck of the diverticulum or from the dome. The endoscopic clipping therapy is quite effective. It induces less tissue injury when it compares to the thermal therapy in the perspective of diverticular disease, and it enables continued treatment without withdrawal of the colonoscope that we need to withdraw in cases of band ligation. So this picture demonstrates that your cap is on. As you localize the site of bleeding, you go straight there, do a bit of suction, and apply a clip directly to the vessel. This is indirect placement in cases where the bleeding is not from the neck but from the dome, and the bleeding is massive or the orifice is small. In such cases, you close the orifice of diverticulum by applying multiple clips at the site so that a local tamponade is generated and results in hemostasis. So this is a case done at one of our center. So you can identify that there are two diverticula. One of it is bleeding actively. As you wash through it, you can see the pulsatility and blood seen coming out of it. So as you identified that this is the site for bleeding and there is pulsatility, you immediately withdraw the scope and mount it with the band ligator and reach the site. At times it is difficult to identify it. So once you identify it, you may apply a clip before leaving so that you can identify the site. And once the clip is applied, you can see that hemostasis is achieved. So this is one way of doing it. One way is clipping and the other way is applying band ligation at the diverticulum. Then we have got injection therapy. It has to be coupled with one of the other therapy. Thermal contact therapies can be used, but as the wall is thin and there is no muscularis underneath, so it is better to avoid or do not use excessive thermal injury. So if you compare all these therapies for diverticular bleed, for initial hemostasis, all three modalities are good enough. But for long-term outcome, the rebleeding risk is less in endoscopic band ligation compared to clips. So then the next cause is angioectasias. It accounts for 15% of lower GI bleed. And when the GI bleed is from the small bowel, it accounts for 60% of the GI bleeds. So this is one of the classification, Yamamoto classification, that it is, if it's less than 1 millimeter, it is type 1A or punctate erythema, and it is bigger one is 1B. Again, we have got a small video whereby an enteroscopy is being done at our center. And you can see some blood coming up every now and then. So the area is being washed extensively to identify from where the blood is coming. So as you wash through it, you can identify this angioectasia with the small clot adherent to it. So again, the blood coming out. So the APC is being done for the angioectasias. So here is the final result. You can see that the angioectasia has been adequately burned. So for angioectasias, if your patient is hemodynamically stable, you use the APC, and if there is response, and response is varied in terms of requirement for blood transfusion and maintenance of hemoglobin. If your patient maintains the hemoglobin, if the hemoglobin falls back, you can redo the procedure every 3 months and do the coagulation. For those who are non-responsive, medical management in terms of somatostatin analog, thalidomide can be used. And for refractory patients, embolization by the IR department, or those who are refractory can be referred to surgery. So the initial result with APC is good in reaching up to 100%, but there are high chances of recurrent and later on rebleeds with patients with angiectasia. Then the next cause, a common cause, is post-polypectomy bleed. In early and late period, it is ranging up to 7% with post-polypectomy bleed. These are the risk factors which identify the patients who have got tendency to bleed after polyp. That is, the polyps which are larger in size, the polyp who have got thick stalk more than 1 centimeter. Those who are in the proximal colon, on the right side of the colon, are more likely to bleed, and the patients who are on anticoagulants or antiplatelets are likely to bleed more. So again, endoscopic clipping is a therapy. There are two strategies that are used. One, you apply a clip directly to the bleeding vessel. Two, you close the whole of the area to avoid bleeding. So this is a short clip whereby a large polyp is being polyp with a small stalk, and first of all, it is being injected to lift. So after adequate injection, it is being lifted from the surface and caught in the snare, and then it is cut, and immediately there is some bleeding. So it is being injected with the 1 in 10,000 adrenaline for a local compressive effect, followed by snare tip being used for coagulation. And once the bleeding is controlled, the underlying vessel was clipped using a hemoclip. And this is the final position. So this is one approach. The other approach is that you close the defect, especially if it is larger and it is on the right side of the colon. You can close it using the zipper technique, that you apply a clip from one side and you, in a sequence, you apply clips. The other approach is that if the defect is larger one, you may apply clips at the ends first, both ends, and that will result in approximation, and then you can apply further clips. This is called modified zipper technique. Prophylactic closure is recommended especially for larger defects more than 2 centimeter and on the right side of the colon. Then the other cause is the radiation proctopathy. In 2 to 20% of the patient, the radiation proctopathy is noted. The incidence is less when you use brachytherapy. Again, a small video showing the patient undergoing radiotherapy for pelvic malignancy, followed by radiation, and APC is being done for the area. Khatam ho gaya time. So in short, for radiation proctitis, you can use APC or formalin soaked gauze can be used for chemical cautery. Hemorrhoids are common, and surgeons and gastroenterologists both can do band ligation. Suction method is better than the forceps ligation. Here, a retroflexoscope showing the varices, and the rectal gun is used for band ligation. Terminal ulceration could be due to infections, acute infections like enteric, or chronic like tuberculosis, Crohn's, and lymphoma. Again, we have got a short video. Here you can see a visible vessel in the ileum, and a clip is being applied. To achieve the hemostasis. So in summary, we can see that the preferred treatment option during colonoscopy for divertical bleed is endoscopic band ligation or clips or coagulation. However, we can also use topical sprays, epinephrine injections, and OTC clips. For chronic angioectasias, the preferred treatment is APC. However, additional treatment available are clip, epinephrine, submucosal injections. And for post-polypectomy bleed, clips are the preferred therapy. However, you can also use direct thermal therapy, APC, OTC, etc. Thank you very much.
Thank you, sir. Now the session is open for question and comments, but due to shortage of time, the question should be short and the answer should be brief. Then there will be a running tea break, and we are going to start the next session at 10:30, 10:15. So you can go for running tea break. So next session is at 10:15. So the time is, I think, over. We should move to the next session.
Excuse me.
Yeah.
I want to ask a question.
Yeah.
Although I should be basically concluding the session, I think, but you are late.
Okay.
All the 5 presenters have done wonderful job. They have done full justice to their presentations. The first one was a medical plus gastroenterology topic related to internal medicine. The one question which I would like to ask regarding that, terlipressin versus band ligation. In the presentation, it was mentioned that terlipressin perhaps has little edge over band ligation. Being an internist, we daily come across such cases, and we at times have to refer such patients to gastroenterologist. So I would like to ask, what are the indications of band ligations in current scenarios in these days where it would be superior to terlipressin? When should I refer my patient from internal medicine to a proceduralist? Because we do offer them terlipressin, but at times we feel that the bleeding is not controlled, and then we have to refer the patient to proceduralist. So I want to listen a proceduralist perspective in that regard, that when we would like to refer our patients to them. An internist perspective is that when we are unable, but how long would it take? Should I wait for 24 hours for terlipressin? Should I wait for how long I should wait, and then I refer the patient to proceduralist?
Professor Dr. Zahid Azam.
Usually, sir, in our practice, and it's written on the guidelines also, the duration of terlipressin is at least 3 days in upper GI bleeding episode. But in our circumstances, as we know, that terlipressin is also a very expensive drug. You have to do endoscopy within 24 hours of a patient presented with upper GI bleed. So if you've done the endoscopy within 24 hours, you can stop the terlipressin in 24 hours if you have done the band ligation. But in the few studies, as you mentioned, terlipressin is superior. It's not superior. It's few studies, but you have to, in acute upper GI bleeding, you have to give the both treatment, band ligation plus terlipressin. The ideal duration is 3 days, but in few studies they suggested that you can give after band ligation within 24 hours. You can give for 1 day is also good.
Yes.
Basically, according to guidelines, there is no optimal timing of endoscopy decided as yet by the expert. We have optimal timing for door to needle time in cardiology, but as Nazish Bhatt said, that yes, within 24 hours, but once patient is stabilized, you have to give IV fluids, and you can stop terlipressin once hemostasis is achieved.
Thank you, madam. Let's move to the next session, and we can enjoy the tea.